Mental health crisis care in the U.S. is in distress. The number of people who are dying of suicide, the struggle of individuals in emergency departments, people going to jail because better crisis care is not available. And a group of us put together the Crisis Now document to highlight that effective strategies are not only possible, but being performed today here in Arizona. 3 key services: an air traffic control call center that navigates and focuses on the person till they get what they need. Community-based mobile crisis that doesn't require someone to go to the hospital, but meets them where they are, on the street, at their apartment. And if they need it, a crisis facility they can go to that will see them right now. Law enforcement can bring them there and go back and do their job. Those are 3 simple things, but they make all the difference in mental health crisis care being effective, inexpensive, and safe for a community. Recent survey by the American College of Emergency Physicians, 8 in 10 said that the community mental health system isn't working for our patients. The need for crisis care is well established. The first issue around the intolerable waits in emergency departments, what we've referred to as psychiatric boarding. In Carolina's healthcare hospitals, it was common for a 20-hour wait. In Washington State, the data showed a 72-hour average wait, but the reality is many people wait for days in EDs. One study found that 1 in 10 calls for services involved a person with a serious mental illness. And those calls tended to take about 3 hours as opposed to an hour and a half for a typical call. The demand to do something different, to have a well-functioning and humane crisis system, is unquestioned. We've modeled 3 approaches. In the first, or traditional, state hospital beds are the go-to resource, and this forces an unnecessary reliance on law enforcement and hospitals. In the second model, we've added key components of a crisis continuum, including a call center, mobile crisis, and facilities. In the third model, or the Crisis Now approach, those 3 resources are deployed in very unique ways. The Treatment Advocacy Center, or TAC, has focused on what is the calculator, what does each community need, and they've determined, by talking with experts nationally, that 50 public psychiatric beds per 100,000 population is the formula. In a population like Phoenix, where there's a little over 4 million, that would mean 2,000 accessible beds, available 365 days per year, and costing, on average, $700 per night or more. If you look at a Crisis Now system, we still have the call center, the mobile, and the facility, but the call center is characterized by a real-time data exchange where we're driving as many resources and interactions as possible to an electronic format. The community-based mobile crisis goes to where the individual is. And the facilities have immediate police drop-off. They drive to a readily available, geographically accessible crisis center. They pull into the spot that says law enforcement. They go to the door that is for law enforcement only. They walk the person inside. Within 5 to 7 minutes, they are back on the job. Now we're starting to make partners of law enforcement and hospitals instead of them being very resentful of us in the mental health system pushing what they believe is our responsibility to them. So the key word here is throughput. And throughput is important because it allows us to connect the individual to the appropriate level of care based on their actual need. The locus, or level of care utilization system, is a framework that allows us to determine an individual's functional and diagnostic need in a crisis. A level 1 means they need outpatient or follow-up support, whereas a level 6 is secure residential inpatient. We reviewed more than 1 million records to determine the most likely scenario of someone in crisis. And what we found is that the most likely scenario was an individual needing level 5 or non-secure residential. This person could be served by a subacute or urgent crisis care facility. And that would be a less costly, less intrusive service than acute care or level 6. Let's compare the 3. The 15% crisis clinical need mapped to 100%, very significant improvement, obviously. But the drop from 108,000 hours of law enforcement to 31,000 hours is freeing up in regards to public safety. Our total drops from $564 million to $267 million. You may say, I come from a community that doesn't have that kind of money, so we can't do any of those three. What I will say to you is, much of that cost you are experiencing. The hospital cost you're experiencing. The law enforcement costs you are experiencing. And then whatever your public sector psychiatric inpatient is, you're experiencing all of that plus some other in the private sector system. In some states, that's dramatic because of a Department of Justice consent decree where you're paying for referrals for additional capacity on top. So it's not really like you get to choose which of these three or you can opt out. No, you're in one of these three. Last year, Phoenix law enforcement engaged 22,000 individuals that they took directly to the crisis system. They dropped them off at a crisis stabilization unit, or they engaged mobile crisis and bypassed the hospital ED. It's the equivalent of 37 full-time police officers. That's a savings for hospital EDs of around $37 million in avoided costs and losses, but it's a reduction in psychiatric boarding time of 45 years. There are social issues, and there is the Americans with Disabilities Act and our Olmstead ruling that has to do with people being supported in communities. And the Department of Justice has been very strong around these types of efforts. We've created a tool for states and regions to assess their readiness for this model, and it's a 5-level system where you assess your call center, your mobile crisis, and your facility. You wrap those up into a full statewide sort of assessment, and then you look at some of the differentiators of peer supports, recovery, safety, engagement, and you come up with a scoring. And we actually did this in a national webinar that was sponsored through NASBID, and the state's self-report based upon a quick swag, understanding the model, was most presented at 1, 2, and 3. A few said they might be a level 4, and no one said they were a level 5.
The state of Arizona crisis system is an exemplary model of how crisis systems could be delivered. There has been a look both at the clinical models, what does it really take clinically to intervene, to do engagement skills, to serve people, but there really is also all these business aspects, and it's the two coming together, having the technology, having the analytics, thinking through the different business structures that an organization can have. Bringing both that and the clinical together is what really makes a difference in delivering care and having the cost savings and the outcomes that we so desperately need.
Crisis Now is a different approach, and it's been fueled, it's been inspired by our successes in Arizona. If we can do that here, it can be done anywhere.